Thank you everyone for joining our first webinar. We are so excited to have you here. Please note that this session is being recorded and will be posted on our YouTube channel. If you would please stay on mute during the session, we will have time at the end for any questions you may have. Without further ado, I would like to introduce our speakers for today. Elizabeth Burrows is an alumnus of North Vermilion High School and graduated magna cum laude from DePaul University with a degree in political science and communications, where she studied abroad at Oxford University. She went on to receive her Doctor of Jurisprudence from Indiana University Maurer School of Law. Elizabeth has worked at the Indiana State Department of Health as the director of the State Office for Rural Health, where she more than tripled the amount of federal funding for critical access hospitals. Elizabeth then returned to Cayuga, her hometown, to start up and serve as the founding CEO of Valley Professionals Community Health Center, which grew over 1,000% in the 8 years she served as CEO. In 2014, Elizabeth started her own business, Burrows Consulting, where she has assisted numerous rural health clinics, federally qualified health centers, institutions of higher education, critical access hospitals, rural health associations, and other nonprofits attain over $95 million in grant funding and over $100 million in enhanced Medicare and Medicaid reimbursement and 340B shared savings. Jonathan North joined our team in March of 2022. Prior to joining our firm, he served on the administration team for an FQHC lookalike. John was essential in navigating their initial designation process and now serves as secretary for the organization's board of directors. He is a 2017 graduate of the University of Georgia Terry College of Business and holds a Georgia Health, Life, Accident, and Sickness Insurance license. John is passionate about expanding quality care to all, and he takes particular interest in how the 340B program can help fuel that expansion. Please welcome Elizabeth and Jonathan. You now have the floor.
Thanks, Hannah, and thank you for organizing this today. We're excited to have so much interest in the 340B program. And our goal is to just give you a taste. This is 101 intro, the basics of 340B. So then hopefully you yourself will be able to investigate and learn more about 340B on your own, to work with our firm or other companies to learn more. And hopefully we'll have some additional training sessions in the future. We have seen the 340B program help various healthcare organizations, and we hope that we can give you some advice on how to help your organization through 340B and how to maximize the benefits of the program. If you have questions, you can feel free to write them in the chat or to email Hannah, contact her directly. And you probably have her email from the reminders about this webinar. Without further ado, we're going to get started, and here is your introduction to 340B. I'll turn it over to Jonathan that I get to work with. I will tell you, working with John is a joy, so feel free to reach out to him. John is our specialist, specifically working with our STI, HIV clinics, and other specialty clinic providers, and he's been doing an amazing job in helping navigate the 340B waters with this process. So John, I'll turn it over to you.
Well, thank you very much for the introduction. I'm very happy to be here today and eager to share with you all sort of the basics of 340B. We'll start with the intent of 340B. This program was created in order to spread scarce federal resources as far as they can go. And there are a number of ways of doing this, but the process for this is to provide comprehensive services or even specialty services to a number of patients. Next slide. So here's a comprehensive list of eligible covered entities, and you can find the list of these on the Office of Pharmacy Affairs website, which we'll cover that later. If you want to take a screenshot of this slide, I'm going to move on pretty quickly here, but the main entities that we serve are federally qualified health centers, STI clinics, tuberculosis clinics, and what else do we serve? We serve HIV clients. Elizabeth, what else do we cover?
Critical access hospitals and rural health clinics, specifically when their parent hospital is receiving 340B, and sole community hospitals as well. But again, there are many opportunities for 340B, so hopefully you can find a way that your organization can fit into one of these.
And our list of clients is growing every day, and the list of different types of clinics is growing every day as well. So if you're a provider and you want to know if you might have some potential eligibility, just feel free to reach out to us. Next slide, please. So This is an overview for the 340B program. I'll just tell you a little bit about it. The 340B program was created to provide outpatient drugs to certain qualified covered entities. Now that sounds like a very strange way to say things, but essentially it is manufacturers offering drugs at a cheaper cost to patients that need it the most. If you're a manufacturer and you want to participate in Medicaid, you're required to participate in the 340B program as well. Basically, this serves as a safety net for providers. Most of the people on this call today are providers, and you all know that providing good medication at a decent price is a very difficult thing to do. This program allows you to expand your services for your customers, for your clients, for your patients, and allow additional services and better enhanced services through those savings created through this program. Some of the benefits are actually estimated by HRSA to save about 20 to 50% of drug savings through this program alone. A lot of our clients actually, Elizabeth, if you want to go back, a lot of our clients actually participate in this program, and they achieve savings in multiple ways. But Elizabeth, can you tell us a little bit more about how 20 to 50%, how do we get that figure? Tell us a little bit more about how that drug savings comes back into the clinic.
Well, again, instead of the drug companies making money or the pharmaceuticals, the pharmacies making money, the profitability from the drug actually goes to the covered entity, so to your clinic to help serve your patients. And so it is difficult to figure. Everybody wants to know, how much am I going to make in 340B? It depends about your providers. It depends on your payer mix. It depends on the drugs that you prescribe. It depends on the client population that you serve. But again, there is a large amount of money to be made. This is, HRSA calls it shared savings. It's not profit, but again, it is a profitability from 340B. And just keep in mind, if you were able to benefit from just the drug costs, if you were able to make 50% of the drug costs of those that you prescribe to your patients, think about what you could do for your patients. Some examples of success have been adding services, adding providers, adding sites, doing home deliveries, helping pay for indigent patient drugs. So the possibilities really are endless with those savings, John.
And so one of the unique things about this is that it actually allows that money from the pharmaceutical sale to come back into your organization instead of going into the pocket directly of a pharmaceutical company. And that's something that this program has allowed providers to do since it was created in 1992. And I'm ready to go on to the next one now. So you must be enrolled in order to participate. There's a specific process for enrolling, and there's a specific process for recertification, which we'll talk about next. But if you're an eligible entity, if you're a covered entity, which is back on that list of the laundry list of the eligible covered entities, you're essentially automatically approved for the program as long as you participate in the registration process and continue recertification. And registration periods only happen 4 times a year, and it's the first 15 days of each quarter. So in order to be eligible as a covered entity, you must be listed on the Office of Pharmacy Affairs database. This serves as the official database for all covered entities, contract pharmacies, and manufacturers. Each site has their own specific ID, and this ID is granted to your institution at the time of registration. And wholesalers are not allowed to ship drugs to you for a discount unless the address is an exact match in the 340B database. And you'll find this a lot with many of the registration activities that you have to cover in order to get actually eligible and get registered and get your organization on the database. And that's something that our organization specializes in, is helping your entity get registered, make sure everything is good to go the first time. And you can explore more about this. I've used the Office of Pharmacy Affairs database quite extensively, so I could show you around if you want to learn more about it. But here's a link here for the actual registration. And so recertification, like I said, it's required for your entity to do this every single year in order to remain eligible. They want to make sure that all of your information is up to date. They want to make sure that everything that you told them last year is the same this year. And with that, I'll actually pass it over to Elizabeth to tell you more about that.
Thank you, John. I remember when I was an FQHC CEO and I was a little scared to join the 340B program. Why was I a little scared? One, I didn't want to go to jail. I didn't think I looked good in orange. I had a baby. I was like, this is just not going to be a good idea. However, now I look back and I look at it the opposite, and I think I missed out on opportunities for some of my patients. I missed out on opportunities to maybe better pay my staff to offer more services. And yes, we did end up being a 340B entity. And yes, both FQHCs that I'm working in still provide the 340B drug services. But again, that compliance piece is a big deal. So you need to make sure that you get certified properly the first time and that you do recertifications for each and every site. It is the covered entity's responsibility, not the pharmacy's responsibility, to make sure everything is set up properly. And again, you want to make sure that you have integrity and compliance and accountability within your organization. And honestly, a lot of that is done through a third-party administrator or a computer program that helps organize all that and keeps track of all the reporting requirements. We're not going to get into all that detail about TPAs or third-party administrators, but they do provide a lot of that accountability that you need. And again, you do have, and they can also assist with helping you contract with pharmacies, and we can do that as well to have those contacts to know how do you actually contact pharmacies and figure out who's going to make you money and where it makes sense to contract with. So again, there's a lot to recertifying and there's a lot to certification originally, but again, it's every one of your sites of the covered entity and then all of the pharmacies, again, that do make proper sense. And that is key because you don't want to register with the pharmacy and have costs associated with that if it's not one where your patients are going to. But there are ways to track that and research that in advance. Again, just to emphasize, I have people call me and they say, well, where's all this 340B revenue going and what happens to it? It has to stay with the covered entity, with the nonprofit organization, with the organization that HRSA has designated for that. There's not a mandate that says exactly where the money has to go, but again, we encourage that to go to benefit patients or to pay your overall costs. I typically tell people you want to spend your grant money and your 340B revenue first, that share savings first, because again, that's what you have to track. Your other program income, you have a lot more freedom to spend that exactly how you want. But again, there's a lot of things you have to do, and this is your chance to sit back and dream. When I teach my grant courses, I always say, have your wish list. This is your chance to have your wish list. What would you want to do for your clients? Is it diabetes education? Is it optometry? Is it podiatry? Is it cheaper drugs? You know, there are tons and tons of things that you can do with this. And I know the needs are great. I've been there. I've been in your shoes. I know that there are tons of things that you want to do with 340B. This is your chance to do that. So this is your chance to have your wish list. What services do you want to provide and how do you want to provide those? And honestly, if I were you during this time, this might be a way to help attract providers to your area. I know that the job market is competitive. Again, those shared savings from 340B could be a way to help bring providers to your patients. And also one more thing on this, I do get asked a lot, what are the reporting requirements? Again, that's really on you and your own CPA and audit firm. At this point, you don't have to, quote unquote, provide a report about where your funding goes. But again, that's something you want to be aware of and have that accountability as needed. Now, this is the exciting part. And I'm sure you're looking at this and you're like, whoa, this is confusing. There's a lot to this. So I just want you to think, hey, if you need to close your eyes for a second and just envision, what could I do with, you know, hundreds of thousands of extra dollars for my patient? So I'm going to explain the process, and then I'm going to tell you a story of a couple clinics that we've been able to work with. So first of all, we all know if you see a patient in a covered entity, any prescriptions that patient is given count, right? The computer system knows that. They know if I was seen at an FQHC, I'm an FQHC patient, and any prescriptions given by FQHC providers that, and again, the computer system will have that NPI, that those prescriptions count, right? That the covered entity can benefit from that. But one element that a lot of people miss, and I literally talk to someone almost every day who is missing this. A lot of rural health clinics miss this, a lot of FQHCs and others do as well. And I understand it's because we're short on staffing or we don't even realize this. But if a covered entity refers a patient to a specialty care provider and the specialty care provider writes a prescription, so let's say hypothetically that you send a patient to a cardiologist, the cardiologist writes the prescription. The patient fills the prescription at a covered entity pharmacy or a contract pharmacy or whatever pharmacy that they want with their other scripts. The covered entity makes sure, ideally, that you've documented patient visit notes from the specialty provider. You've documented the referral. The rules are extremely vague, but there is some sort of documentation. And then again, the covered entity and or the third-party administrator look at the prescriptions from the provider NPI. And the computer system will say, oh, wait, we know that Elizabeth got a prescription from her FQHC, but now she also is getting prescriptions from a specialty provider, from IU Health and from Mayo Clinic. Do those qualify? They won't automatically qualify because those provider NPI numbers are not in the computer system, but it's enough that the TPA or the computer system knows, wait, these are questionable. Maybe they can qualify. And then at this point, it's on the covered entity to make a referral claim for that prescription. So again, the FQHC can go in and say, yes, we do have the documentation about IU Health and Mayo Clinic for Elizabeth Burrows, so we can claim those drugs and we can then reap the benefits of those drugs. Just to give you an example, we worked with a very small lookalike in between Indiana and Ohio, right on that border. And we worked with them. They had 2 rural sites, very small. They each had 2 to 3 providers. This is not their total money made on 340B, but solely in capturing referrals. We worked with them and used our registered nurses to track the specialty referral prescriptions. And solely in that, we made them almost $175,000, sorry. So just over $174,000. So imagine if we divided that per clinic, that's about, $80,000 to $90,000 per clinic that just has 2 providers. Think about what you could do with that to help your patients. And again, they made a lot more than that in 340B overall. That's solely in just referral capture. So there can be a lot of funding, additional funding that you can gather. So I encourage you, make sure you have your staff tracking these and working the list, or that you contract with us or someone else that's able to capture those referrals and getting all the drugs possible. Again, most people know to claim what is being prescribed by the covered entity, but a lot of people leave money on the table with capturing these specialty providers. Again, just to go over, everyone always asks, how's the 340B discount work? So we're just going to try to make it simple. And this is for a $1,000 drug. So again, total reimbursement for the drug commercial insurer is $900. The 10% you get from the patient. So so your third party's paying $900, the patient's paying $100. The manufacturer provides 340B entities with the discounted drugs, so they get $600, and the health center gets the $400 difference. This is just meant to be an example, just to show you that, again, some of it still goes back to the drug company, the manufacturer, and your costs for administering 340B. But again, you're able to get a large percentage of the difference. And again, I know there's a lot of questions and a lot of information. And if you start down Googling 340B, you're going to be down a rabbit hole that will have lots of information that's completely overwhelming. And you're just going to want to just take a nap. When I get overwhelmed with information, I just want to go to bed and take a nap. I can't even process it. And honestly, that's what happened to me as a CEO. I just became overwhelmed. And I was like, I don't even know if I can process all of this. But there are resources available. Apexis is who the Office of Pharmacy Affairs contracts with, and they provide a lot of free resources. There are all kinds of free webinars and free classes. I will say their goal is to scare you to death. It's like any government program, right? They're going to say, these are all the things that could go wrong. And so I say to take some of these workshops with a grain of salt, but they do offer some great information. And they, again, have a helpline that my company uses a lot. We go on there and ask questions. They're extremely responsive via phone and email. Again, they're a government contractor and they really do provide some of those answers for you. Here is how to contact them. There's their phone number, their email, and you can also go to their website. It's very easy to navigate. So I encourage you to use this as needed. Please know that we're here to help. We want to help you make connections. There are ways that you yourself can become a covered entity, or that you can partner with a covered entity and reap benefits from the 340B program. So there are all kinds of terms like subrecipients, Ryan White lookalikes, FQHC lookalikes. There's contract arrangements, MOUs, all kinds of different relationships. In other words, ways that you can become friends and working with a covered entity in an official relationship that you yourself can also benefit from 340B. And we're glad to assist with that. So again, our services specifically will work with 340B, grant writing, consulting. These are our specialties: rural health clinics, rural health centers, DHCs, FQHCs, federal and state grants, and community and foundation grants. We're glad to help you with that. Or again, helping lately, I feel like we've been helping people make friends with someone who is a covered entity. So feel free to reach out to us today. This is our website. Here's our email. And I think that covers all the basics right off the top of my head in our presentation. And now we're glad to answer any questions. So you can feel free to unmute your line or enter your question in the chat, and Hannah will help organize those. Or again, you can email Jonathan. Don't email me. I'm not going to be checking during this webinar, but you can email me after and I'll be glad to respond later. And I know sometimes I always think of things later, and we will be offering this recording. So again, if you're watching this recorded later, feel free to email us so we can answer your questions as quickly as possible. And so we'll go ahead and start with questions and answers. Hannah.
Awesome. Thank you so much, Elizabeth and John. I know it was a bit earlier in the chat, but someone asked if we will be sending out a copy of the slides. Yes, we will be emailing the slides and the recording, plus the links that Jonathan and Elizabeth mentioned tomorrow. So be sure to watch your email. If you do not receive that email tomorrow, feel free to email me at hannah@burrowsconsulting.net. Another question that just came in is, if I am a critical access hospital, can I determine if the 340B program will benefit my facility? Is there a way to determine that ahead of time, Elizabeth and Jonathan?
Yes, there are. So you actually, if you want to email us, we can put you in contact. The third-party administrators that work with the drug companies, they can do an assessment. You have to provide a list of the NPI numbers of your providers and whether they work exclusively for you or somewhere else as well. And we can assist on getting that assessment for you to see if it does make financial sense to do this. I will say about 95% of the time it does make financial sense to do it, but there are times and certain states are not quote unquote as 340B friendly. So it just depends on that. But most of the time it does make sense, but we're glad to help do that assessment. You would want to capture the people prescribing drugs at your facility, and then also anybody working in the hospital-owned clinics, provider-based clinics, rural health clinics, et cetera, with that critical access hospital.
Thank you. Next question that came in is, if a specialist we refer to is also a partner with 340B, who would get that savings?
Okay, well, this is fun. Finders, keepers, losers, weepers. That's really the answer. And Apexis is going to tell you. So whoever claims that first is going to be the person that reaps that shared savings. So again, it's based on computer and who claims that first, but that is how that works. I will say, don't automatically assume someone's set up in 340B. We have that happen a lot. I've heard people say, well, it doesn't make the hospital say that doesn't make sense because there's an FQHC, they're already capturing everything. Oftentimes they are not capturing things. So just know, don't make assumptions on that. Do a full analysis, do the proper research, because again, this can be a huge deal for people. And capturing those referrals, that is for all our providers. So a lot of people think in the HIV world, they think, well, it's just the drugs for HIV or sexually transmitted diseases and infections. But again, if those other diseases are related in some way, to HIV or STI, then you can capture those referrals. In the FQHC, RHC setting, you can capture any referrals, again, because you're providing primary care. So no, that does apply to all of them.
Thank you. And then Carrie asked if a DSH eligibility, is DSH eligibility only for those who are acute care? There are also psychiatric that are also DSH eligible. I don't know if Carrie, we need you to expand on that, or Elizabeth, you understand?
So she's talking about DSH hospitals. I don't want to just make a whole declarative statement because I would have to research DSH hospitals, but I do know being a disproportionate share hospital and having a high percentage of Medicaid does qualify you. So that's something I would want to look into more with the psychiatric component. John, do you agree? We just have to do some research, but I believe either way it qualifies you, but I don't want to say that 100%.
Yeah, it's a little tricky because everything you'll notice is a little bit tricky with this, but that's why we're here. We'll look into that question and follow up with you on that.
Make sure Hannah has your email. I'm sure she does, but we have that connected so we can get you the answer, Carrie.
Yes, I will follow up with you, Carrie, on that. Thanks for that question. And next question, we are an independent RHC in California. We are not affiliated with a hospital. Do we qualify?
So a couple things. John, you want to talk about a couple ways they can qualify, and I'll add on to that too. John was the same way. He worked at an independent RHC and he figured out ways to qualify. So go ahead, John.
So there are a number of ways to do this. Probably the most common one is to become an FQHC lookalike. That's going to be your bread and butter to get that, and that gives you those comprehensive services and that access to the total spectrum of the 340B savings realm. There are a couple other ways too, and it depends on what state you're in. A lot of the states that we've been working with will work with providers that see different patient populations to provide sexually transmitted infection services. A major way that happens is through federal grants that offer test kits for you to use at your convenience and to perform broad range testing, very large numbers of testing, or whatever is needed for your area. Elizabeth, do you want to add anything to that? We've been working with a lot of STI clinics, so and it's kind of complicated on how to access it, but California has a very large number of these STI clinics.
So again, it's providing certain services. If you are caring for the indigent population, that usually helps you. And we've even been able to get some for-profit organizations on 340B if they are caring and for the indigent population and serving everyone. So used to, people would always say you had to be nonprofit. We have been able to get a few for-profit organizations on board. It just depends on your state regulations. Again, it is a federal program through the state, but John's right. The easiest way is to look at and explore the FQHC lookalike to get enhanced reimbursement, the 340B program, and automatic HIPS and MUA, and the other benefits of that.
Awesome, thank you. I did have a couple of questions come into my email. So first, have you heard of any covered entities getting in trouble with compliance for 340B?
Well, again, I think that goes back to all of you. Have you seen that on the news? Yes, every so often you do hear of someone getting in trouble, but I will tell you, I have never had any of the organizations we've worked with get in trouble. I have not really heard of anyone getting in trouble with 340B. As long as you're doing the right things, you will not be in trouble. As long as you are serving your patients and again, doing proper documentation with the proper policies, there really are no issues. So really, I have never worked with anyone that's had issues with that. Have I heard of people? It's just like the HIPAA breaches. You hear of it, you do deal with it once in a while, but really, I have never worked with anyone or been aware of anyone that I've known that has been in trouble with 340B. But I can tell you story after story after story of people making 6, 7, 8 figures off of 340B for their organizations. And that's what's really important. Thank you.
Thank you. Next question, this is from a provider. Can you let me know what drugs prescribed would I make the most money on?
Okay, well, that's like asking a financial advisor what stocks you're going to make money on this week, right? Or next week. So it really varies day to day. And so that's the same with the 340B program. That's why you have your computer program, your third-party administrator there to help answer questions, and they can monitor all the time what what pharmacies make sense for you to be affiliated with and what drugs are on your formulary. I will say if it's a drug that you see on TV all the time, or if you know the catch song because you hear it in ads regularly, those are probably medicine that you're going to make a lot of money on. Drugs to treat HIV and a lot of psychotropic meds can make money. But again, there's a lot of money to be made out there with 340B medicine. Typically it is name brand drugs. It's not drugs that you're going to find on the $4 list, but it does vary greatly. And again, you'll want to have that relationship with your third-party administrator to help monitor that.
Perfect, very helpful. Next question, you mentioned specialized clinics earlier. Can you tell us more about how to access 340B as a specialized clinic?
So we touched on that just a little bit a second ago, but back to you got Black lung clinics, hemophilia diagnostic treatment centers, Title X family planning clinics, SCD clinics, and tuberculosis clinics. The majority of these are not open right now for access. So even if you wanted to apply, you'd have to get like a certificate of need, and you'd have to have your state back you, and it's a very lengthy process. And I don't know, I'm not sure exactly when the last one was designated, but it's been some time. The STD and tuberculosis clinics are ramping up because of a number of initiatives that are focused towards eliminating STDs and HIV and tuberculosis. And that's been where we've seen the most activity of registrants here lately. But the best way to find out how to get access to this is to reach out to us, because we can look into what's exactly going on in your state and find out the best plan to move forward for you.
Perfect. And there is Elizabeth and Jonathan's contact information on the screen. The QR code on the left also will take you directly to our website. Like Elizabeth said, you can sign up for a free 30-minute session with us, and we will definitely be able to help you. And then I just have one more question. Oh, looks like there's one in the chat now as well. Are only medications prescribed to patients with commercial insurance Medicare the ones that can benefit from? Medicaid patients without insurance do not provide financial benefit, correct?
Well, the answer to that is yes and no. I get it. That's a lawyer answer. Everybody wants a clear answer, but the answer is yes and no. One, it depends on your state and whether your state, because you cannot quote unquote double dip with Medicaid. So if your state's already getting Medicaid rebates, you can't also benefit from 340B. However, there are ways to get it carved in and work with your state to allow you to participate. Also, as states move toward managed care organizations, managed care entities, and managed Medicaid, those are allowed to be utilized, as well as Medicare and private insurance. And again, your self-pay patients will benefit, assuming they qualify for your sliding fee scale through the program. So the big benefits, again, you are correct, Medicare and private insurance, but there are ways that Medicaid patients, assuming they're not on traditional Medicaid, can work for you, or even if they are on traditional Medicaid, you can work with your state to try to reap the benefits of that. Thanks.
Perfect. And I know we mentioned it just a little bit, but is there a comparison between generic and name brand meds?
So again, that's where you have to work with your third-party administrator to know, is there differences between generic and name brand? The goal is that, again, from a patient perspective, they see no difference. From a provider perspective, they should prescribe the best drugs for their patients. So I remember one time I literally got into kind of I wouldn't say a yelling match, but it was a heated discussion with a doctor who said, Elizabeth, I can't prescribe certain drugs to my patients because they're never going to get it. It's going to cost them more and they're never going to go get that prescription. And I calmly told her, I want you to prescribe the best drug for that child for their ADHD. I don't care what it is, you prescribe the best drug. Don't let cost be a factor. And oftentimes our providers are fearful to prescribe certain drugs, thinking that it will cost more. What I'm trying to say is prescribe the best drug. Whatever it is, if it's a name brand drug or even generic, there are times that you can make money off that. And if not, and the best drug doesn't make you money, that's fine. It's still a win for the patient. You're still serving the patient. But again, that's really not a headache that you need to have or that we need to have. That is where the computer system or software can monitor that and figure out what pharmacies allow you to make money and what drugs are making you money. And again, your providers are just to take costs out of the equation and prescribe whatever is the best drug for your patient.
Perfect. And a last question, unless we have any more being put into the chat, why is it not everyone participating in 340B?
Well, that's a good question. A few answers to that. And John, you can feel free to chime in. Sometimes we don't know what we don't know. And so people assume I tried to get on 340B 10 years ago and we didn't qualify, so I'm done. They're fearful of the compliance issues. Maybe they don't even realize how to qualify. Oftentimes things change. Now you are the sole community hospital. Maybe you were a critical access hospital, now you're not. So you think you're out of the game. You haven't thought of other innovative ways that you could be a part of this. Sometimes we don't even realize the benefits. I have people oftentimes call me and they say, I just want the enhanced reimbursement for FQHC. They don't even realize that that does qualify them for 340B and the funds they make. Or even more commonly, I have people call me and say, hey, Elizabeth, write me a grant. And as a grant writer, I'm excited. I love to write grants. I wrote my first grant at 19. And ever since then, I've been a grant. I'm addicted to them. I'm a grant addict. But the bottom line is, I do try to tell people, hey, as great as it would be for me to write you a grant, if we can get you a status and get you on 340B, that is going to be sustainable. That's going to be sustainable funding in the long term. And so you don't have to hire me 3 years from now to write another grant or write the grant renewal, that's going to be funding that sustains you. And honestly, most of my clients, and I do write grants for most of my clients, and I want to continue to write grants for most of my clients, but I would say a huge majority of my clients, if not over 90%, make more money off the 340B drug program than they do off of grants. And I think I'm a really great grant writer, but the bottom line is there's more money to be made in this program than there is in grants. And as we all know, sometimes grant programs dry up. The 340B program has been around for years and was set up for many of these organizations years and years ago.
Perfect. And she is a great grant writer, by the way. Just
thank you, Hannah. Thanks.
Last question, going back to those covered entities, are rural hospitals eligible for the 340B program?
It depends on your payer mix. It depends on your status. Many rural hospitals are, and I would say we can probably get a huge majority of those qualified, but I cannot speak specifically to your need. I would need to know exactly where you are. So please reach out to us individually. We can try to help figure that out for you. Because are you a sole community hospital? Are you a county hospital, public entity? Are you a critical access hospital? Are you a DISH hospital? What's your payer mix? There's a lot of things we would need to answer. This stuff does get me excited because I love to figure out all the ways around the rules to get everybody qualified to better serve their patients. And again, I just want to thank everyone for your time. We really appreciate you taking time out of your busy schedules, and feel free to reach out anytime. Our goal is we're going to do some more webinars this year and probably in early 2023. Oh man, can we believe we're saying that? In early 2023, we'll probably be doing 340B 201, kind of beyond the basics to help learn more specifics. So again, feel free to reach out to us, and John and I and Hannah will stay on. If you have questions, we'll be glad to answer those. You can unmute your line.